Okay.
So welcome everybody. My name is Dara Yanowitz, and I'm an officer of the Jewish Community Federation and a very proud member of the Cleveland Jewish community. I'm really excited to see how many of you are Zooming in with us today. We are truly in an era of physical distancing ourselves, but we want to remain communally close.
Yep.
One of the core strengths of our Cleveland Jewish community is its commitment to caring and providing for others. And to that end, we, the Jewish Federation of Cleveland, are creating these platforms, these webinars to help people understand the impact of COVID-19 on our community. We want you to have a chance to ask questions directly to experts. On Sunday, we hosted a webinar with Dr. Shelley Senders to understand how to celebrate Passover safely. I know I learned a lot from that. And today we are very proud to host Dr. Robert Salata to talk about safely caring for someone with coronavirus. Today we have a number of people, and people are still rolling in. I see well over 50 people on our call so far. And I want to thank the Federation for providing these wonderful opportunities for all of us to have a chance to learn and be updated from our experts. And I also just want to take a moment right now to thank all of our Jewish Community Federation professionals. They have been working tirelessly to keep our community up and running and healthy and responding to needs. So my thanks to my professional partners. And now it's my pleasure to introduce Dr. Robert Salata, and I can't imagine a more qualified person to present to us today. Dr. Salata is chair of the Department of Medicine at University Hospitals, Cleveland Medical Center, and physician-in-chief for the entire UH system. He is an internationally renowned expert in infectious diseases and global health. Dr. Salata joined UH in 1985 and served as chief of the Division of Infectious Diseases and HIV Medicine for nearly 20 years, as well as executive vice chair of the Department of Medicine for 7 years. He is also the medical director of Infection Control and Prevention. He's the professor of medicine, international health, epidemiology, biostatistics at Case Western Reserve University School of Medicine. So if anybody's going to have the answers today, Dr. Salata, I know it's you. Everyone remember there's a Q&A box. Please feel free to submit your questions, and after we hear from Dr. Salata, we'll have a chance to have him address as many of them as we can in the time allotted. So Dr. Salata, the floor is yours.
Thank you. I would be remiss if I didn't also tell you that I am the program director for the Roe Green Center for Travel Medicine and Global Health. And she's a great member of the Jewish community as well. And it's been a pleasure to interact with her.
Thank you.
Let's talk a little bit about this virus infection and where we're at. This started, the first reported cases were in late December in China, Wuhan, where I've actually been, and I went to that marketplace where they think it all started. It was an incredible experience. But soon thereafter, a number of cases of an identified respiratory illness were being seen in China. And this really has now reached what we call a pandemic. There were 3 legs, to call it that, by the World Health Organization. One is that it's a brand new disease that causes death. Number 2, that it was easily transmitted from human to human. And thirdly, that it based transmission that's recognized around the world. There are increasing numbers around the world. In the United States, we just hit a little over 50,000. But fortunately, our death rate has been in the United States so far on the order of about 1.3%. There are several hotspots in the domestic United States that are seeing this in greater numbers than we are in Cleveland. We could talk about that, including New York City, which is probably the biggest, LA, Seattle, where this first landed in the US, and it got into the older nursing home population there with devastating effects. And as well in Boston to an extent. There is concern that this will really take off in Florida, where many older individuals live. And the other thing, however, to make a few points clinically. One is that about 80% of people described so far who are positive by testing really have mild and at most moderate disease. They have recovered for the most part without specific treatment. We could talk about treatments that are available these days. And it's only a subset of folks that have gone on to die. Those have been identified as generally being older, 70 years of age or more. The average age in Italy, for instance, right now of those dying is 80. And especially those that have chronic underlying medical conditions, such as heart disease, lung disease, diabetes, hypertension, being actively treated for cancer, or they have immune compromised systems. Interestingly, this has not been seen in a significant fashion in pediatric age groups, fortunately. That compares to, for instance, in 2009, when we saw pandemic influenza, H1N1, where that disproportionately affected younger age groups. And fortunately, we have not seen devastating effects of this yet in pregnant women, because that is the case with influenza. So it is increasing exponentially in the United States, in part because we now have testing available, whereas we did not before. And we still don't know whether death rates and the total number will change once we can embark on more testing. And that's been one of the major challenges, aside from trying to protect the public and our healthcare workers against this virus in that context. So I'll just end up by saying that I fully agree with the aggressive measures that our governor has taken, along with our public health authorities, including stay at home now and lockdown, because we have several principles that I think have been shown in other countries to work, such as social or physical distancing, which we like to call it the latter now, because we want people to be socially connected, as well as hand washing or hand hygiene as much as possible, cleaning our environment, and staying away from people that may be ill. All of these are important measures. And if you look at bending this curve or flattening the curve in terms of the number of cases, this has happened in China. And those of you that are staying closely informed about this know that within a week, they're going to open up their businesses again, their orchestra, their banks, you name it. But it's back to business for them in many ways. And so that can be accomplished. And I think if we take that as a comparison, as well as what happened in other countries like South Korea, Singapore, we could be in for this for maybe about a 4 to 5 month period before it starts to diminish. Do we have to stay secluded like we are for that extended period? Maybe not. And maybe many of you have heard about the Trump administration saying they're going to reevaluate 2 weeks' time to see if they can start lifting some of these restrictions. But these measures have worked, and I think that's the most important thing, despite the fact that this is very cumbersome, it's very, very anxiety producing, and but there will be an end in sight. There is some treatments, and at university hospitals, we just started 2 intravenous antiviral treatments. The first patient was enrolled today, and that's for moderate to severe disease with a drug called remdesivir. It's made by a pharmaceutical company called Gilead. And however, there's lots of interest in other therapies, including an old anti-malarial drug called chloroquine, and a kissing cousin of that called hydroxychloroquine, often combined with a common antibiotic that we may have received as a Z-Pack called azithromycin. But I would just emphasize, very importantly, that if we're going to really know if these are beneficial, and because some of these drugs have significant side effects, we don't want to just start using them without really studying their effects with respect to safety, efficacy, and things like that. So we've seen a number of people try to get prescriptions for these drugs and use it preventatively. Right now, there's no indication that that can be done, although the drug chloroquine has been used in the past for prevention of malaria, but that's where the state is. And lastly, I keep saying that, a lot of things happening. Vaccine trials will start in the United States as of April 1st. These will be conducted by the National Institutes of Health, but we probably won't have a vaccine ready for use in the general public for at least 12, if not 18 months. That's just the amount of time that we need to establish that they're safe and thereafter efficacious. So I think we have a ways to go with the vaccine as well. So I'll end there with that introduction and see what questions everybody has.
Great, thank you. And don't forget, you please submit a question on the Q&A button. We have a couple of here already. So some folks are asking, with us being on the upswing on the curve, more and more people are getting sick, hopefully not so severely. If we have an ill person in our homes, what is the best way for us to care for them, and who stays where?
So the point about social distancing or physical distancing is an important infection control principle. And we do know that this virus is transmitted mainly through the generation of what are called respiratory droplets, which are created by coughing, sneezing, or even prolonged discussion like we're having right now. So that's an important thing, to try to distance yourself from people that may be known to have this infection or are suspected to have it. Right now, it would be nice, wouldn't it, if we could test a whole swath of people in our area and elsewhere through the country. We just don't have enough tests. So we are triaging or prioritizing those patients that will be tested right now until we have the ability to test more broadly. And right now, we have stood up our own test at university hospitals, but we also have access to the Ohio Department of Health for specimen testing, and also commercial laboratories. There are 3 of them now. So we have greater ability to test, which has been one of the major challenges so far in this whole process. So we are testing at our lab those folks that are hospitalized, because they turn out to be our sickest, and we have to know, because indeed we now have some potential treatments available for them as well. And secondly, we're testing our own healthcare workers that are exposed to someone that had this and then developed symptoms. For the general public that develops symptoms, and we could go through those in a few minutes, but the most common ones are, there is a way for their physician to call our hotline at university hospitals, and then we can get them in the queue, and we have 2 options in that regard. One is a drive-through process where people stay in their cars, they're asked questions, if appropriate, they're swabbed, and samples are sent. And the other is our own home care unit has nurses associated with 7 of our teams, and they can go into the home and obtain specimens as well for testing. Many times in the drive-through scenario, we send those out to the commercial labs. They take about 3 to 5 days to come back for the results. People are very anxious during that period. But those that are done on site here, as is the case in the Ohio Department of Health, that turnaround is 12 to 24 hours. So in terms of protecting everybody, I think it's still important. Hand washing, hand washing, hand washing. Using alcohol that is, alcohol rubs that are 70% or more is very important. And as well, keeping your safe distance, but not to the point where these loved ones are ignored or anything like that.
Okay, thank you. We have lots of questions starting to come in now. Here's one. A household member is in an essential job. He is in the house with someone with COVID-19, or alternatively with someone in self-quarantine because of a primary contact. With either scenario, can that household member who is not currently symptomatic safely go to work without concern of spreading disease?
Yeah. So that's a great question. And the answer is simply yes. But they need, when going to the workplace, if they're an essential worker, to practice those same types of infection control practices. And, this will also be such, pardon me, in the setting wherever they're at, minimizing their exposure to larger groups. At university hospitals, we're using a total of 10 people or less, and we've really gone virtual in almost every circumstance now. It's changing the paradigm of how we see patients. We never want to forget that face-to-face encounter with patients is so critical in terms of the physician-patient relationship. But with telemedicine and a number of other things coming into play, I think is changing the paradigm forever, in my view, in terms of how we're going to be interacting for the future. That said, I do think the question you asked, that person can go as long as they remain asymptomatic. And if they do develop symptoms, they should not go to work.
Okay.
I saw a study not too long ago that suggested that among all businesses, large and small, that it was possible to keep people remotely working in only about 30% of cases. So it's something to keep in mind. However, there's been imposed in Ohio now by the governor more strict measures for that. And I think we're learning that we can be very productive at home too. And Zoom meetings just like this are a great way to interact. And I do that with my family, for instance.
We have a number of young adults coming back from either different places in the country where they are adulting, or a number also coming back from Israel, where they had been spending time either in school
Right.
or at work. Who should automatically go into quarantine?
So Israel would be an example of where somebody
Do we
should.
just throw those 20-somethings in the closet?
Exactly. So I had the great fortune of going to Haifa, my first trip to Israel in early February. So I missed all this chaos. And it's the place where a university exists called Technion. Many of your folks may be familiar with it. And we have an exchange program that we're really pushing forward in terms of medical students and possibly some research opportunities there too. In fact, starting in July, 2 Technion medical students will be joining our internship. But that said, they're the so-called hot zones in the United States. And if those students are coming back, they should be awfully careful. And we mentioned several of those up front. And it's amazing to me, for what it's worth, that you see all these pictures of these students, college-age students, especially on the beaches and not practicing physical distancing, et cetera, et cetera. So they think they're invulnerable all the time, and I think that is something that the parents have to take more control over. But if they're coming from areas where lots of transmission has occurred, I think it's reasonable for them to cohort themselves and self-isolate for a period of time, make sure they don't develop symptoms. The symptoms that are most common with this include a non-productive cough, fever, though interestingly, in the Chinese experience, only 60% of individuals had initial fever at onset. Later on, they all did, but therefore 40% did not at the beginning. Shortness of breath, I mentioned, could be a harbinger of more severe disease. And the other thing that's come up more and more is gastrointestinal manifestations, nausea, vomiting, diarrhea. Unlike other respiratory viruses, this one has been found in stool, and diarrhea has occurred in up to 50% of these individuals and may be the first sign of the coronavirus syndrome coming on. So those are the things, particularly the respiratory symptoms, that one should focus on in terms of those students coming back, what they need to look for self-monitoring, et cetera. So I think it was a good question.
If someone is considered high risk, either by age or vulnerability, should they be social distancing from everyone, or, and they were also asking, or is 6 feet
6 feet is what
acceptable, but that is what we consider physical
exactly.
distancing now.
And
So
it's
do they
not
need to
only,
do any more?
yes. So great question. It is not only the 6-foot radius, because that's where these respiratory droplets are expelled. And we haven't talked about the environment, how long they can last there, right?
Right.
But it's also being in that person's space that we just spoke about for 5 minutes or more cumulatively. Okay, if they were symptomatic and transmission either way. So I think that's the rule of thumb we're using. And we could stay away from, people for 6 feet, but not socially isolate them either. That's the important thing here. And the environment can be also contaminated. There are recent studies that show that, it could last for up to 9 hours and sometimes longer, up to 96 hours. So part of the strategy in your homes, your business settings, et cetera, is to make sure you're disinfecting your workplace and things like that. And, cleaners like Clorox wipes, Lysol wipes, et cetera, if you can get them from the grocery store and other places, would be quite adequate to deal with that as well. We don't think it's transmitted in food, and everybody's doing takeout these days. Just well-cooked food is fine. It kills the virus. And there's been a recent study that shows it's not on mail and other things that you receive in that way, okay? Others have asked about contractors in the house, caregivers that come to the home, and things of that nature. And I think they should be screening, self-monitoring themselves. If they have fever or respiratory symptoms, that's a no-no for coming into the household. And they should maintain their distance as well. We don't have enough surgical masks for everybody in the United States to be using them, though some people are trying to do that as much as possible. And the Surgeon General, among others, has come out against that, trying to salvage those masks for use in hospital settings. That's very important because there is a shortage of what is called personal protective equipment for our healthcare workers, and we have to safeguard them too. If our healthcare worker population is decimated, that's going to a formula for disaster. And that happened in Italy, for instance, among other things, that drove the surge there.
Someone's asking, as far as the percentage of deaths,
Yep.
in reality, isn't it much lower just because of the number of limited testing and we don't really know who's had it?
It probably is, but it is still at a slightly higher level at this point than we see with influenza. But this season alone, there are 33 million people infected with influenza. Another reason to get vaccinated, right? Although the vaccine is maybe about 45% effective, but it's still better than zero. And most of our older vulnerable patients, even if they're vaccinated, I'm sticking on influenza for a second, still have, if they develop it through the vaccine, they have milder disease, they die less frequently. But there have been, generally speaking, 30 to 60,000 deaths in the US alone each year from influenza and associated complications. We're not at that level yet, and I think that's important to keep in mind. The total numbers in the United States are, the death rate is still about 1.3%. So it is lower, but as the surge continues, that remains to be seen if it remains at that level. We hope that it does, and that's important. It goes back to the point that I made before, that a large proportion of people probably are infected asymptomatic, but yet we don't know that because of our testing strategy. And there are 80% of people that do test positive that have mild disease and recover completely.
And probably one of our last questions, implications for pregnant women.
Yeah, great question. So we know from other illnesses, infections particularly, that pregnant women are more susceptible to not only acquisition of those infections, influenza is one great example of that, and also more severe disease. Fortunately, so far, in many of the countries, and we don't want to necessarily say this is always an apples to apples comparison, but that has not been seen so far in pregnant women. Furthermore, in newborns of women that were shown to be positive, at least in China, there were no consequences to those infants so far. But it is an important question, and we do recognize that pregnancy, in essence, is a quasi-immunocompromising state because of the ability of women to carry the baby, et cetera, and not reject it. So we are being extra careful with our pregnant healthcare workers, and that's part of our strategy, and we're still including them among the list of folks that we would be worried about. But fortunately, that doesn't seem to be the case. And I also mentioned that so far, younger people and children especially do not seem to have very severe complications. There are always exceptions. There is a recent story about a football player from Louisiana, I know Texas, and Texas Tech to be exact, and he died recently of complications of COVID-19 infection. So we can't forget about that across the age spectrum, but fortunately, it does appear that there's less involvement with regard to severity infection and death among the younger age groups so far.
And finally, Dr. Salata, if it should happen to come that we have someone in our own homes with the COVID-19 tested positive, we know they're sick, hopefully not taking them to the hospital with severe symptoms, how do we care for them? What do we give them? What do we do for them?
Everything you always have done, but keeping that distance that we talked about before.
Chicken soup, then?
Chicken soup is the best, right? It has great medicinal properties. So all of the things that you would do for a loved one in that scenario. You should be mindful, everybody, that this can be a biphasic illness, however. So for the caretakers to know that initially there may be a relatively mild period of symptoms, and then it can escalate significantly. And those are the individuals in those vulnerable populations or the elderly we need to watch very carefully as to whether or not they need to be hospitalized in the end. And the one thing I mentioned before, shortness of breath, is one thing that could be a major indicator of their going on to more severe disease.
Well,
Okay.
Dr. Salata, thank you so very, very much for your time, for your expertise, for your wisdom. I know I learned a lot, and I can see how many people have joined us on the call and have stayed through the whole thing. They really appreciate it as well. I just want to speak to those of you who have joined us on the call right now, remind you that our federation is looking to support you through this challenging time. If you or someone you know is struggling in this increasingly difficult time, please contact Access Jewish Cleveland at 216-292-INFO. That's 216-292-4636, or access us online, accessjewishcleveland.org. We have arranged for a therapist from the Jewish Family Service Association to be on the calls from 9 a.m. until 5, Monday through Friday. You have the information up there on your screen. I hope that you found this informative. We will try and do more of these as we can. Please continue to wash your hands, practice physical distancing, but community togetherness. Thank you, Dr. Salata. Community, stay tuned, take care of each other, and stay well.
Thank you so much.
Thank you.
My pleasure.